Thank you. Yes, I'm Carol Parise. I'm with a researcher from Sutter Health, which is a healthcare organization in Northern California. And I'm going to talk about cannabis for cancer, patients that are using it for chemotherapy and for symptoms of cancer. And I'm going to talk about the quality of life issues that they can help and maybe help. So the goal is to integrate cannabis with modern medicine. So rather than say, okay, I'm going to use cannabis or I'm going to use traditional medicine, we want to try to integrate it. But in order to do that, you have to know how it works and what it's best to be used for. So cannabis has been used for centuries in many cultures for cloth. It predates humans, and it's been used in Chinese medicine for forever. But William O'Shaughnessy in the 1800s was an Irish physician who pretty much brought cannabis to the forefront for treatment of epilepsy and rheumatoid pains. And at that point in time, Bayer jumped on it and created medications with cannabis to use in about a third of their marketed drugs for various reasons. And it was widely used before became illegal in 1937 when the marijuana tax was enacted. But attitudes are changing. Cannabis is now legal in 38 states for medical use and an additional 24 for recreational use. So we need to talk about what cannabis really is, because you hear marijuana, CBD, THC. So the cannabis sativa plant contains multiple agents. So the tetracannabinol acid, the THCA, is a non-psychoactive product that's in all raw cannabis. And because it does not become psychoactive until it's heated and it converts to the psychoactive product THC, which is what gives you the high. CBD is short for cannabidiol, which is related to THC, but it's not psychoactive. And it usually comes from the hemp plant. So hemp is a type of cannabis that contains less than 0.3% of THC. And then when you hear marijuana, it's not synonymous with cannabis. It's a part of the cannabis plant that has the substantial amounts of THC. So there's multiple methods of delivery of cannabis. Smoking and vaping is what everyone thinks of recreationally. Edibles have become more popular because of the legalization. It's made into candies and all sorts of other products. And then topicals, rubbing on, and tinctures, which you put on your tongue, those are other ways that it is ingested. But smoking and vaping is the most, it has the fastest acting time because you're sucking it in, and the THCA is converted to THC, and the effects occur within 2 to 3 seconds and then can last 2 to 3 hours. Edibles are a little bit more variable in how they act because they can either have THC or CBD in different combinations, and the effects can be felt anywhere from 30 minutes to 2 hours and may last for 5 to 8 hours. But the issue is you take it and you might not feel anything right away. You might take more, which could lead to taking too much. And topicals and transdermal patches are even more variable because it depends on where you put them on your body and, again, the ratio of THC and CBD in the products. So the reason patients with cancer use cannabis tend to be to counteract the effects of chemotherapy, which include nausea and vomiting, pain, anorexia, sleep, and anxiety and mood problems. But the research on all of these isn't particularly strong in some areas. Some is better than others. So that's what I'm going to get into. I'm going to talk about the different studies on use of these products for these different issues. So there is evidence for cannabis use as an antiemetic. So in a multi-center randomized double-blinded placebo-controlled trial, which is like the gold standard, this was a crossover study. Patients were given the THC CBD product or given a placebo, and then they swapped out. And then they were measured on their vomiting and their complete response, not having to use the rescue medications. And when they had the CBD THC product, 25% had complete recovery. They had no vomiting and they did not need to take their rescue medications. In the placebo group, 14% had that. The other interesting piece of this was that at the end of the study, they were asked, would you rather what you had the first go around, or when you swapped over, would you rather have that product? And most of them said they'd rather have the THC CBD product. So that's a kind of a push in the direction that, hey, this might work. The other key piece of this, though, is they all had their standard antiemetic drugs at the same time. Those were not eliminated from their standard of care. So there's a synthetic cannabinoid medication called dronabinol, and it's FDA approved as an antiemetic, but it's not as effective as the standard of care antiemetics. So it's generally not prescribed. And the NCCN guidelines don't recommend cannabis for treatment of chemotherapy-induced vomiting and nausea, but ASCO kind of takes a page from the study we just looked at. They say, hey, dronabinol and nabileone, which are both cannabis-based products, could potentially be used to augment your standard of care medications for nausea. So pain. There's insufficient evidence to show that cannabis can reduce pain. But what it has been shown is that it could potentially reduce the amount of opioids that people are using. And there seems to be a sweet spot where if you use too much, it makes the pain worse. And so one of the biggest studies on this was 38,000 patients with newly diagnosed breast cancer, colorectal cancer, and lung cancer. There was in a state that went from no legal cannabis to legal cannabis, they found that there was a reduction in opioid prescriptions and pain-related incidences with newly diagnosed cancer patients from the time it was not legal to the time it became legal. So there is evidence that it could potentially reduce the amount of other pain medications being used. So anorexia, you would think, based on social, that take a hit and you're going to eat everything in the room. The interesting thing is in the systematic studies, where people looked at all the studies on cannabis and anorexia, there wasn't a lot of benefit. There was not enough evidence to show that this really worked. And that's when they used megestrol as a comparator, which is the standard of care medication for anorexia, or a placebo. So these were high quality trials, but the evidence was really limited and they had small sample sizes. So the largest study that kind of shows this might not be the best thing for anorexia is in 469 patients with advanced cancer. And they were randomized to either receive a cannabis product, which was dronabinol and placebo, or megestrol, which is the standard of care medication. And the megestrol group reported greater gains. So it's not really been shown to be very effective for making people eat more. Now, sleep aid is another thing that you would think would be, hey, this stuff works. Everybody has CBD gummies now. It seems to be the thing. But in all of the studies out there, there's not a lot of evidence to show that it's really effective for helping with sleep, even though there is widespread use. Anxiety's got a little bit more beef behind it. So in a 10-patient trial of patients with anxiety, a single dose of CBD lowered anxiety on a CT scan. So that's a fairly solid endpoint. And it was only 10 patients, but that's a pretty solid endpoint. And then in a double-blinded trial of patients with social anxiety disorder, a 600 milligram dose of CBD was able to reduce subjective anxiety induced by a simulated public speaking event. But I think the best study that shows it's got potential for anxiety, and it might have to do with the makeup of the product, was done in Colorado. And so it's legal in Colorado. And so they found 317 people with anxiety disorder who also used cannabis just in their everyday life. And they randomized them to 3 different groups. One with a THC dominant product, one that had half THC CBD, and then one that had more CBD than THC. And at the end of the day, the CBD dominant forms of cannabis were associated with acute tension reduction. So this seems to have the most promise. So why don't we have more research on this? And it's because it's illegal. It's a Schedule I drug, which means that there's no current acceptable medical use at this time. And so it's like it's got a high potential for abuse, which is like heroin and LSD. So research requires approval from your own institution. You've got the DEA, and you probably have an IND because that's the FDA. And then it has to be the product you use. You can't just go down to your local dispensary and say, hey, you guys want to collaborate on this study? You give me the product, we'll do the research. You can't do that. You have to use an approved researcher synthesized product or get something from the National Institute on Drug Abuse. And if you want to do research on cannabis and you don't have a safe in your office that's in the wall, you need a 750-pound safe, a $300 DEA license that's going to last you 3 to 14 months. And it takes 95 days for that process to happen, just the regulatory process for the DEA. That doesn't include your IRB and your FDA. But times are changing. It looks like we may have a potential that we can be doing more research on cannabis. Just this last May, the Justice Department suggested a move of cannabis from a Schedule 1 to a Schedule 3. Schedule 3 is like a moderate to low dependence, like ketamine and testosterone. And the 2018 Farm Bill, so that says you can do research with cannabis that's less than 0.3% THC. But the kicker of this is that when they introduced this bill, you are required to use a DEA licensed lab in order to test to make sure your product had 0.3% or less of THC. So that it overwhelmed all the labs. They got rid of that requirement because they can't keep up with it. So I think we're going to see more CBD research ahead. So that brings me to a study that I did with my colleague Deepti Bell, who is our research medical director. And she and I put together a study several years ago because we wanted to know what patients with cancer were using cannabis. Who were they, and how did they use it? How much did they spend, and did they really find out that feel like it worked? So the population was the Sutter Cancer Center in Sacramento, and then 12 other cancer centers across Northern California. And then we also enlisted UC Davis Medical Center, which is about 4 blocks from our office. So patients were given the option of completing a survey in the waiting room before they were having treatment. And they asked whether they used cannabis, yes or no. And we wanted to know the differences between the people who said yes, the people who said no. And the people who said yes, we wanted to know about the reasons for use, how they used it, and did they feel it was beneficial, and how much did they spend on it? So we started out in 2017 where they just completed a paper survey. COVID happened. Suddenly we got into QR codes. So we put the QR code up and we were able to expand the study because we could just go in the office, push the QR code, and people could fill it out online, and then we didn't have to do the data entry, which was nice. So when we looked at the users versus the non-users, we had a good population of people. And it turns out that the users were younger. They were less likely to be Asian Pacific Islander. But we didn't find a race ethnicity that was more likely to use it. Patients with brain, gynecological cancer, prostate cancer were more likely to use than not. And those in stage 3 and 4, and those who are undergoing chemotherapy were more likely to use cannabis. So when you put all these variables together, we wanted to see what really stuck out. So we adjusted for all the other variables in the model. And we still found that younger people were still more likely to use cannabis than older people. And that Hispanic, Pacific Islander, Asian Indian were less likely than any other race than whites to use it. And all the other races were very similar in use to white people. And stage 4 cancer still stood out, and those with chemotherapy also were more likely to use. So the reasons they used, of all the 625 users, over half stated they used it for sleep, and 46% said they used it to reduce pain and anxiety. Edibles and multiple methods were favored by over 60% of the people, and 68% when you combine the vaping and the smoking, either vaped or smoked. So our big question to them was, how did you feel like this helped you, or did it help you? So on a scale of 1 to 10, we asked them, of each of the symptoms, how bad was this particular symptom before you used cannabis, and how bad was this symptom after you used cannabis? And it was on a scale of 1 to 10, and then we compared the before and after. So if you look at the results, the blue is the before line, the orange is the after line. And in all cases, these are all really statistically significantly different. But the pain, the anxiety, and the appetite all stood out as being the largest differences. But they didn't spend that much, which surprisingly, I thought they would be spending more on this, but most of them spent $100 or less. And then after that, it was $100 to $200. So conclusions, younger patients with higher stages of cancer with chemotherapy are more likely to use cannabis. Most used it as a sleep aid and vaped, smoked, or used multiple methods. And despite the lack of overwhelming evidence, patients reported it was most effective for decreasing nausea, pain, and increasing appetite. But it was a biased study, and you're going to find this in most of the studies out there, is that when people buy their own cannabis and they're more likely to say, oh yeah, it worked. There's just a natural tendency to want to think that what you spent your money on, it was really helpful. So we know that. So considerations for use. Now that we know all of this, the question is what do you do with the information? And the first thing to realize is addiction is still real. And if patients with personal family history or themselves of addiction shouldn't be encouraged to use that because it's not good. And there are a lot of side effects. Tachycardia, orthostatic hypotension, confusion, obviously you shouldn't drive. And a study of patients without cancer found that there's liver enzyme damage just in patients who were taking 300 or more milligrams of CBD per day. And patients under 25 years old should be discouraged as the prefrontal cortex isn't fully developed until age 25. So some studies have found that use by adolescents is associated with decreased cortical thickness. So what happens when someone says, hey, I really want to try this? The recommendation is to start small. Like 3 milligrams of THC equivalent is a reasonable place to start. But inhalation is more predictable. I mean, you don't really encourage someone to go out and smoke, but if you want to know if it works quickly, that's the way to do it. And if you take edibles, make sure you gotta wait 4 hours or so because you may not have an effect. And you'll take another and then you're gonna be not good. So there's a lot of drug interactions too that you have to be aware of, that it can increases the level of other drugs. So patients that are on warfarin, seizure medications, statins, erythromycin, if you don't know that, and you need to know that these drugs that people are taking these drugs if you're going to use cannabis. So again, the final word then is to encourage discussion. So a small UK study found that people use the complementary therapies based on sources of information that they have, what they hear, what they may see on TV, their friends, potential mechanisms of use. But a belief in the trust in the therapies of their caregivers is also another reason that they may or may not use something. So it's important to discuss with your doctors, and the doctors need to discuss with the patients. Because patients are using them. Regardless of physicians' attitudes, 80% has shown, some studies have shown up to 80% of patients with cancer are using complementary therapies, but they're not telling their physicians, which could lead to side effects. So the ASCO guidelines suggest that clinicians routinely and non-judgmentally ask patients, are you using cannabis? Have you thought about using cannabis? Just so to make sure that they're willing to discuss that with you, because if not, that's when you're going to end up with too much warfarin or too much of or orthostatic hypotension. So that's all I have. So do we have any questions? Yes. You must have a reputation.
Well, one or two things you did. That's amazing. 20-something years, and we smoked before that and afterwards. We also found, once it became legal in the state, she went to see a doctor, nurse who would prescribe it, and had a nice discussion because she had some cancer issues also. And she said a particular plant to buy or weed to burn. We found that, and we found the one brand, not the one brand, but the one plant, particular name, did wonders. We found other ones didn't do anything. So that seems to be a bigger problem when you go to the gummies and so forth, because you're getting combinations of many plants and so forth. What we also found out with the two plants, and she stocked up on them. She passed away a year and a half ago. I still have stuff at home that we stocked up on because they stopped growing the plants, because the plants weren't producing enough leaf for them to manufacture, so they go after the bigger leaves that they're producing out there. So, and I could go on, and we can have some nice discussions. Where you're doing all this research, are you also taking particular plants and not just CBTHC? There's difference between plants because of the chemical analysis of the THC that's in there and the CBD, and they're still finding other things in certain plants depending where they're grown, what chemical mixtures or so forth are in there. And I could probably go on. I hope everybody hears it, and I'm curious of your answer and why they don't go for the plants yet.
You nailed the problem with the research. And that's the one thing I noticed in all of these studies that you look at. Nobody talks about that. And part of that is the difficulty in doing the research and having to use a standardized medication. The Dronabinol and the Nabilone are the ones that they can do the research on. They're not doing them on the particular plants, and that's what we need in order to find out if this really works. You need the type of plant, you need what's in the plant, you need where it's grown, the strength of exactly. And so that it's in growing variability. It's just like wine. I mean, you've got when you have different locations, are going to make a different plant. And right now, it's too difficult to do the research because you can't just you can't do it if you don't. The money, for one, the government can't fund the research. If you're going to do research on cannabis with government money, it has to be a survey type question. It can't be we're going to provide you with a cannabis drug. So that is, you nailed the exact reason why it's so difficult to say when this works and how it works, because the compounds are just also different.
And I would suggest, I hope everybody hears me. I can talk loud. I get out there. But I think if anybody's going to try the smoking, depending on, if you have plural, it's rough with the lungs and everything, and there's other ways of getting leaf smoke into you that's a lot cleaner and so forth through certain burning methods, which I think is good. But try a variety. One of the things we found with gummies was we had them imported from California, was 20 to 1 ratios. 20% CBDs, 1% THC. Yeah. They also have the reverse, where I find some people go take it. Oh, I got a CBD, and shit. Yeah. Right? So that's where you have to look at combinations and look at things. And now, anyone who wants to talk later, no problem. Thank you.
Hi, I'm a fan of medical marijuana. My husband used it for sleep especially, but I was hoping you could take a minute to just debunk some of the things that are out there, because I think cancer patients are especially vulnerable to scam cures, and one of the ones that I hear about a lot, my brain wants to call it Rick Steves oil. I know it's not Rick Steves, he's the Europe guy, but it's something along those lines, somebody's oil. And if you could just talk about what products specifically to avoid.
So I can't talk about which products to avoid, but what I can do is tell you to go to PubMed. If you are going to use a product, if you are looking at it, do your research, because you are right. There are so many. I was looking into some complementary therapies for arthritis 6 months ago. And when you look at the studies that are done, a lot of times what they're doing is they're taking the results of animal studies and they're generalizing them, an injection in an animal, and they're saying, okay, this is going to work as an oral supplement in humans. And somebody markets that. There's no regulation of those products. So my suggestion, there's a natural medicines database. You have to pay for it, but that is one of the better sources of information. It tells you whether or not something, how much evidence is out there for a specific product, and whether, or none. And you'll go down, you'll see none, none, none. And suddenly they'll say, oh, this particular product, there is some. So I think that's your best bet is to PubMed. Don't just Google. You start with Google, and it's going to give you every ad you've got and every product out there. That's how they're selling them. So that's my suggestion, is that I can't specifically debunk which ones do and don't work.
Pardon me. Has your research addressed? There are some who would argue that cannabis or marijuana is an entry-level addictive drug that could lead to more dangerous, more dangerous drugs in addiction. What does your research show if that's true or not, or especially within a cancer community?
It's shown in patients who have a family history of addiction or a personal history of addiction. But I haven't specifically looked at patients with cancer, any studies in that area. But the family addiction and the personal addiction, if you have been addicted to anything, alcohol, anything like that, there is an association of addiction across types of products. So if there's an alcoholic involved, then you're probably going to be likely to be addicted to cannabis also. And is it a gateway drug? Could be, but not in everyone.
When you guys were doing your study, did you guys take into account, especially in California, the people that were home growing and how much they were spending monthly on their cannabis use? So the people that were growing their own plants and making their own gummies, and then kind of looking at how much they were saving in prescription cost for opiates versus people who were just using opioids for pain management, and those who were using homegrown THC and opiates to kind of offset that cost and what the savings was on insurance companies and on the patient overall?
Yeah, no, we didn't look at any of that. And one of the reasons was that if we wanted to hook patient prescriptions up with the amount, with use or no use, and ask those types of questions, we couldn't anonymize the study. And so we anonymized this. So there was no names or PHI on anything that we got in the surveys. But I like that idea. That would be great to be able to determine. So again, the opioid prescription reduction, and then in California, most people are yeah, yeah, yeah. It's interesting. We have a very good dispensary near our hospital that we've talked to. And, that's the other piece of it, too, is you've got to find someone you trust. If you're going to go to a dispensary, you want to talk to people who know what's in their product. They want to know where you're getting it. Those are really important to know, because you don't want somebody who says, oh, yeah, this only has 5% THC and it's 24% CBD, and it turns out that it's the other way around. You want to know what you're taking. And that's half the reason that one of the reasons that we don't have a lot of answers on whether or not this works, is that you just don't know what's in a lot of the stuff you're getting.
I had a question as it relates to immunotherapy. Mm-hmm. Your study's obviously focused on chemo, and I've gotten advice from my doctors that on immunotherapy, it can actually suppress immune system, THC, and just what your thoughts are, if there's been any research or studies.
This
on
is
that.
one where I wish Dr. Bell was here. She is our oncologist that could tell you a lot about that, but I'm not qualified to talk about that.
I think that's where you say that speak to your physician before
this is where you want to talk to your physicians, and if you've got more than one, you can talk to, see what where you get multiple insights on.
There's been
things.
guidance on that with ASCO though, and so I think the best decision for anybody is, I'm not a physician, so I don't give advice, of course, but for anybody who's on active treatment, you should always speak to your physician before taking any type of integrative or alternative herb supplement medication, anything like that. And this falls under the same category.
If not, tell them to boost up your treatment while you're smoking. And this way you cross it out. It works.
I'm South California. My brother grows plants. There's a dispensary that is working with me. Purplicious, the strand. that they suggested for me for pain. I hate taking Oxycontin. I hate the fentanyl patch.
They can't hear you.
I'm on fentanyl patches and Oxycontin. I don't like taking those drugs. My brother grows plants. He works with a dispensary that they suggested purplicious plant, which is for pain. Okay, this I've been on it for so long, and it helps me. It does help me mentally because of the pain is so, you're on edge and you can't function because you're concentrating on that pain. But it helps me, and I'm staying on this. And my doctor, all my journey, he does not discourage it. I can't do the gummies. I pass out. Point blank. Like the smoking, I can't do it either. But I do the vape, and it's like that's it. I'm cool. Yes.
And that's what it comes down to, the
Yeah,
plants.
it does. It comes down, yes.
Any other questions? Okay, thank you, Dr. Parise.
Thank you.